Dr. Magaki, George, ladies and gentlemen. It's a real treat to be back here at the scene of the crime. I met two young ladies in the cafeteria this noon that came here within a month of the time I came here the first time in 1946. One of the ladies came here in January, and the other one came in February, and I came in March. So it's really great to be back. That's 1946 it was. Some of you weren't even alive at that time, I suppose. I was pleased to see that the title of my talk was Mammary Neoplasms and Neoplasms, the mammary gland of dogs and cats, because I was afraid that somebody would follow the example of our British colleagues and they'd call it tumors of the breast of the bitch. And I find that, I guess it must be my early training, but I find that I kind of wince a little when that is said. It's a perfectly proper thing because that's the name of a female dog. I guess I'm conditioned by the fact that a friend of mine was working in a pet shop one summer, and a young matron came in, young lady, with a little girl by her hand, and they were looking at dogs, and this young man said, now, this little bitch here is purebred and it's about 4 months old, and then he'd say, now this bitch is such and such. And every time he said this gal would wince. And he said, I noticed you seem to flinch every time I use that word. And she said, it's the problem I'm having is that I've not heard it applied to dogs before. And the little girl had picked up a puppy, and she was fully in the mood by this time, and she said, how much is this little bastard? So we are stuck with words at times, and they don't always mean the same thing. Well, in order to talk to you about mammary tumors and try to share with you some of my own prejudices and experiences, and to confess my confusion, I think you should understand what my experience has been with this very interesting problem. I came here to the old Army Medical Museum, which is down on 7th and Independence, in 1946, as I've said. And at that time, I had a chance to study a large number of mammary tumors which were submitted to the Registry of Veterinary Pathology from all over the country. And at that time, our problem and our aim was to get some understanding of at least the parameters of disease in animals. And we were receiving a rather large number of specimens from practitioners from all over the country. And I began to appreciate the complexity of the mammary gland in the dog. And then in 1957, I went from here to Angel Memorial Animal Hospital, and I was dealing then with several clinicians who were interested in the clinical outcome of mammary neoplasms, which had been removed surgically. So then my objective became to try to convey some useful information to my clinical colleagues and to help them in dealing with their problems. In other words, give them information that they could use that had some bearing on the behavior of the lesions. And here I think I became a confirmed lumper. I think I did more lumping at that time than I maybe should have done. But anyhow, I am a confirmed lumper. If you don't know what a confirmed lumper is, well, maybe you'll get the idea as we go along. Now, in 1968 or thereabouts, oral contraceptives were administered. The programs were started administering oral contraceptives as a part of the toxicology testing programs were administered to female beagles, and many of these started to develop after a year or so some palpable nodules. And I've had a chance to see some of these things that have occurred. And here the problem is somewhat different in that we are trying to see and interpret histologic lesions that occur in the course of a study and to communicate some idea of their probable biological behavior. And I think I'll pose some of the problems that this does entail as we go along. But here again, the problem is to determine what these mean, these lesions mean in the mammary gland of the bitch in terms of biological behavior that could be interpreted as action of a drug. And I don't pretend that this isn't a difficult problem. Those of you that are struggling with the lesions and trying to interpret them, I think you'll agree with me that it is difficult. There's such a widely varied histologic appearance in the mammary gland of this species. And we also have some difficulty in interpreting their biological behavior. The studies on their biological behavior have not been as comprehensive as they should be. And many of the things that we should know have not been documented. And certainly many of the endocrine and genetic factors are hinted at, and we think we know something about them, but we really don't understand them. On the other hand, there is some relationship to the histologic appearance of mammary tumors and their eventual and subsequent behavior. The histologic features tend to be similar in the primary neoplasm and in the metastases, so that we can very often tell with certainty that we're dealing with a secondary neoplasm if we know what the primary looks like. And as long as we remember that we use the histologic characteristics to identify a neoplasm, and don't try to say that from those characteristics we can predict what a neoplasm will do, we're on fairly safe ground. So it's a matter of recognizing the lesion using histologic techniques. And this is the area that I'm going to talk about. So we can recognize them as you recognize the face of a person. You get so after a while you recognize them instantly without much fooling around. And if you remember their name, you can put a name on them. But you really can't predict from what their face looks like what they're apt to do tomorrow or any other day. And you can't unless you know something about what they've done in the past. And then you may make some prediction what would happen in the future. And that's the situation that we have to consider in dealing with these particular neoplasms. Now, through the courtesy of Colonel Casey, I've studied the WHO set on the mammary tumors of the dog and the cat. And I find it very interesting. It's been done very carefully. And by looking at the slides, the Kodachromes with the text, one can get a fairly good idea of exactly what's meant. We have to remember that this was prepared under several stringent situations. One is that most of the people were either from, the pathologists were from Europe or Australia, and so they were an international group, and they had to learn to communicate and use, translate their terminologies into some kind of a common language. And they obviously had many different views at the outset as to how the thing should be looked at. They were also constrained to compare the mammary tumors in the dog and the cat to the human classification, which had been worked out by WHO, which had some of the same problems. And I find that it clearly brings out to me that I've been a lumper, and they are splitters. In other words, they have a tendency to define the categories and provide classifications that are much more based on much more detail than I have been used to using. So I'm not saying this is, I think this is a good basis for future study, but I find it a little complex for me to use. But you probably going to have to decide on your own scheme of classification anyhow. For example, there are 13 types of carcinoma, 3 sarcomas, and 1 malignant mixed tumor. So there's 17 different categories of malignant tumors. And I find that I recognize only 8. But I recognize one that they don't include, so there we are. So the other thing that's a problem is that the mammary gland is very subjective, but very much subjected to the endocrine status of the animal. The amount of estrogen, the amount of progesterone and prolactin, other enzymes in circulation influence the gland. So we have endocrine situations that are variable, we have aging situations that are variable, and we have whatever the etiologic characteristic factors are interacting. So if we may have the first slide. The mammary gland results from the downgrowth of epithelium from the skin. And this forms small nodules which eventually, under the stimulation of estrogen, proliferate, and these ducts send out branching ducts which eventually become either acini or form additional lobules. This becomes a lobule, and the connective tissue in this lobule is somewhat different and is stimulated by estrogens. It's somewhat different than the interlobular connective tissue, which we'll point out in a bit. There's another thing that I don't know that we can show it to you here, but around each acinus, as they form, there are cells around the periphery which are somewhat polyhedral shaped, flattened cells that are contractile cells that are called myoepithelial cells, and I'll refer to these again. Their origin is from the epithelium. They are contractile, and they have very interesting potentialities. So eventually these ducts grow down and form, as they branch, they form interlobular ducts which produce acini, and then it has its own characteristic stroma, and then there's an interlobular stroma between these lobules. This is a lobule that's larger than normal. Till eventually the lactating gland is in the furthest extreme. It's quite different in appearance. It's obviously, but here is a interlobular duct, and then the acini, which contains secretion. And it's quite a different looking gland than a resting mammary gland. So we do have to think about the kinds of changes that the mammary gland can go through during the various stages of the estrous cycle and through pregnancy and lactation. The next, first tumor I'd like to talk about is the Adeno Carcinoma. Now it's made up of epithelium, which either form tubules or acini, which has a tendency, a property of invading the stroma, like these acini are doing, these tubules here. It has the property of invading the stroma and a peculiar type of hyaline connective tissue around these bits of adenocarcinoma are referred to as desmoplastic reaction or desmoplasia. They may have necrosis. They may form solid nests in places, but for the most part, they are acinar in their structure. They may extend into lymphatics or venules. This is a clear indication of tumor cells in lymphatics. This is the adenocarcinoma. They may show this feature with tall columnar cells with a double row of cells, which very much look like apricant glands, as contrasted to this more undifferentiated acnes over here. It's sometimes a problem to know whether these are simply apricant glands that are invaded with tumor, or whether this is one of the features of the morphologic features of the adenocarcinoma. I think in most cases it is a feature of adenocarcinoma. In this case, we have quite a bit of inflammation, quite a few plasma cells and lymphocytes, also in the stroma. Another feature that can occur in an adenocarcinoma, here's part of the adenocarcinoma, here's a dilated duct, is the proliferation of myoepithelial cells. And these are fairly characteristic, and when you see it, it's not too difficult to recognize, although it is a problem sometimes to distinguish whether this is connective tissue or myoepithelium. It takes some experience to be certain about it. But I'll talk about this a little bit later, but you can see that there's an intimate association with ducts and with acini. Their epithelium and this myoepithelium are very much admixed. Now, one of the terms that's used in the WHO classification is complex. They use the term adenocarcinoma, anaplastic carcinoma, or medullary carcinoma, and they're either simple. If they're simple, they're made up simply of these glands. If they're complex, then the myoepithelial elements proliferate. A myoepithelial tumor could also be simple if it did not have the glands that go with it. So that's the difference in this WHO classification. So this would be a complex adenocarcinoma. To illustrate again the intimate association of these myoepithelial cells. Here you see they are sort of stellate, spindle-shaped with elongated nuclei, and they're very intimately associated with the epithelium, which they tend to compress and push off to one side. Here it's clearly evident that this is growing out of a wall of an acnes. It's very closely associated with it. So this is myoepithelial proliferation. They also may be intraductal, they may be papillary, as this one is. Illustrating the papillary characteristics of some adenocarcinomas. This would, in the gross, they may be solid, lobulated, as this one is. They may have cysts in them with hemorrhage and necrosis. They may have evidence of necrosis or perhaps even calcification. I think this is necrosis. They may, and usually do, eventually invade lymph nodes, particularly the axillary and the inguinal, and then spread to other organs. The metastases occur to the lung. As in this case, the metastases of various sizes in the lung. They may metastasize to the liver and elsewhere. So a very brief picture of what we call an adenocarcinoma of the mammary gland. The next category is the Adeno Acanthoma. It's a term that does not occur in the WHO classification, and although about 8% of the canine tumors that Dr. Gilmore and I studied a few years ago, there were 356 tumors, 8% of them were considered in this category, as compared to, I think, 51% of the tumors were considered as adenocarcinomas. It may turn out that this is a case of the lumper doing some splitting that he shouldn't have done, or it may be that the Adeno Acanthoma does deserve a separate category. My present feeling is that it does. It behaves more like an adenocarcinoma than a squamous cell carcinoma, but I think in the WHO classification it is included under the adenocarcinomas. But you see, in this one, it has a structure of a large lobule. It has some proliferation of myoepithelial cells. And we first look at it, it seems to be mostly tubular, but there are a few solid areas. And this, I think, illustrates the squamous metaplasia that occurs in these tumors. And some of them, one will see places in which it looks like they're basal cells, which could be interpreted as squamous epithelium if you wanted to. But very often there will be frank glands and acini right adjacent to the squamous epithelium, and this will also occur in the secondaries. Just a higher magnification to indicate what we consider the acanthomatous part of the Adeno Acanthoma, which you can accept if you want to, or whatever you want to do with it. But the fact is, this tumor also may be very large, with areas of necrosis, with areas of hemorrhage, and they may become to be quite large lesions. They metastasize to the lung, to the liver, and elsewhere. So the next category, which is much smaller, consists of about 6% of the canine tumors that we reported, 356 of them, are considered squamous cell carcinomas. And in this tumor, although it may occur in parts of a gland that may also have an adenocarcinoma in it, or some other neoplastic lesion, the characteristic of this lesion is the large sheets of squamous epithelium, which may undergo necrosis. And of course, the very characteristic squamous epithelium with the loss of polarity in the cells and the very definite squamous characteristic of the cells. And as I mentioned, that the WHO classification puts the Adeno Acanthoma, which I consider Adeno Acanthomas, in with the squamous cell carcinomas. Okay. Another category, which I've called solid or medullary carcinomas. Perhaps solid is a better term, because medullary carcinoma in the human subject is somewhat different and doesn't seem to fit this category, and perhaps we should use the term solid. But the characteristic is the presence of solid masses of epithelial cells, which may be conspicuous or may be fairly slight. In this case, I picked this field because it does illustrate that acini do occur, or glands do occur, in the same tumor. So it may have solid areas, and it may have glandular areas. A little higher magnification, and also a metastasis to the lung to indicate that these solid masses of cells do metastasize to the lung. And occasionally they'll form acini, as this one has here in places, but most of them, bulk of the lesion will be solid. And these cells may be elongated, sort of spindle-shaped, and I find that I've been putting what the WHO classification calls the spindle cell carcinoma under this category of solid carcinoma or medullary carcinoma. But this is also, as I am illustrating here, a malignant tumor metastasized to the lung. This is the same case in a metastasis to the liver. These liver cells over here. And interestingly enough, this particular tumor is one that most commonly invades the dermis over the mammary gland. You see the tumor cells, which are individualized or in clumps, very rarely forming an acinus, are invading the dermal lymphatics. This is the dermal epithelium here. Under higher magnification, you can see this solid nest of tumor cells that's in a dermal, probably in a dermal lymphatic, but anyhow, it's invading the dermis, and this very often gives a characteristic gross appearance that some distance from the mammary gland, the skin will be sort of fixed and very tough, and the underlying dermis is obviously very thick. The epidermis may be slightly eroded or congested or eroded in this rather characteristic fashion. And once you see it a few times, you can easily recognize that it is a malignant tumor and probably a solid carcinoma invading the dermis, dermal lymphatics. Now, the next category is the Anaplastic Carcinoma, sometimes called Undifferentiated Carcinoma. I suppose the anaplastic is the better term, although either one can be used. And this comprises about 1% of the mammary tumors that we have seen in the dog. I wonder if we could sharpen that. It doesn't look quite in focus to me. I don't know. Thank you, Mr. Brown. I think that's better. But the characteristic of this tumor, in this case here, I think these are in lymphatics or venules, but the tumor is made up of individualized cells which have very little cohesiveness with one another. They tend to be easily separated. They occasionally undergo necrosis, they very often undergo necrosis. And here this one seems to be invading part of say a hyperplastic gland, mammary gland. But these are highly malignant. And here's another such lesion in the lymphatic, and I believe there are cells perhaps out in here that are also carcinoma cells. They're individual cells which they're too large to be lymphoid in origin. They're clearly adenocarcinomas, and once in a while one will find that they will form acini or some solid nest, but most of the time they form these individualized cells. So they invade the lymphatics and they metastasize just like the others that I just spoke about. The problem of the myoepithelial elements and the problem of what's been lumped under the term mixed tumor is one that will probably be with us for some time. The first I encountered this problem was in Rosemary Biggs's paper, and it came out in the early 1930s, in which she spoke of the myoepithelial elements proliferating and giving rise to cartilage, bone, which may become hematopoietic, giving rise to osteosarcomas, or chondrosarcomas. And although that was sort of a shock to everyone who believed in the three primary layers, like the entoderm, the mesoderm, and the ectoderm, and the two giving rise to epithelium, and the mesoderm only giving rise to mesenchyma. And it's still questioned, but I have yet to see anyone who really has challenged it effectively. And that is that these myoepithelial cells, under certain conditions, and particularly in the mammary gland of the dog, do proliferate and give rise to many different situations. The thing that I pointed out before is that this myoepithelial proliferation, which is closely associated with epithelium, with the ducts or with acini. And without much difficulty, particularly in an early lesion, one can see this without any hesitation. It's when the lesions become much larger then the problem becomes more difficult. Now, some people, some pathologists will speak of a mixed tumor as a tumor which has a mixture of myoepithelial elements and epithelium. The WHO classification meets this by calling those that have proliferation of both of these elements as complex. In the WHO classification, they have also done exactly what the conclusion I came to years ago, that the only way I could possibly separate out the mixed tumors without having most of the tumors as being called mixed would be to only accept those that have cartilage in them. So that is sort of an arbitrary decision that I won't call anything a mixed tumor unless it has cartilage. And Dr. Misdorf does the same thing. It's a sort of a way of solving a dilemma. And part of the dilemma is the fact that this epithelium may proliferate and may become malignant. The myoepithelial cells may differentiate to form what's beginning to look like cartilage, or it may be frank, clearly well-differentiated cartilage. And that usually develops in this part of the stroma. This one, I don't think I'll try to convince you that that is cartilage, but many of the tumors don't go much further than this before they do have cartilage. Now, the mixed tumors can be solid, single lesions. They can be lobulated. They can have cysts in them, as this one has. They can have solid bone, which may develop a hematopoietic marrow. They may be lobulated, as this one is, solid, and a fairly good size, as you can see. They may be cystic, as the Adeno Carcinomas are, with hemorrhage, necrosis in them. And they metastasize. They can metastasize. Here's metastasis to the lung, 2 metastases to the lung, or several metastases to the lung, I should say. Metastases, they may metastasize widely to the kidney, brain. Here's one in the cerebral cortex. Now, the parts of the mixed tumor, since it's mixed because it contains epithelium, which may or may not be malignant, it contains this myoepithelial element, which may or may not be malignant. Now, it may metastasize as an adenocarcinoma. It may metastasize as a mixed tumor with both elements carried along, with the cartilage and all, or the myoepithelial elements may become malignant and undifferentiated, as in this case, and we have a frank osteosarcoma. I would consider this an osteosarcoma because of the nature of these cells, these very large spindle-shaped to stellate-shaped cells, which produce osteoid here. And they also may produce a chondroid matrix and clearly evident osteoid, which may undergo calcification. And as I say, it may become bone, or it may develop a hematopoietic marrow. So this is an osteosarcoma, and this has all the aspects of an osteosarcoma. It has nothing else in it. And in the gross, And this particular tumor was solid. It did have some evidence of there might have been necrosis in it in places, but it was a solid expanding lesion, but it also invaded lymphatics and did metastasize. So this is the osteosarcoma. Now, those are the malignant tumors that categories that I speak of clearly malignant tumors. But they really don't present the problems to the pathologist. The problems come when we consider all the other lesions. And it isn't possible for me to go into all of them. I'm not going to try, except to pose part of the dilemma. For example, here is a circumscribed lesion that's perhaps encapsulated, but at least it's definitely growing by expansion. It's compressing the adjacent tissues somewhat. It's made up of epithelium, which forms tubules. And most of us wouldn't have too much difficulty in considering that to be an adenoma. And here's another one, which is also circumscribed, clearly demarcated from the adjacent normal acini. It's not so clearly encapsulated, but it is apparently growing somewhat by expansion. It's not any larger than that one we saw in the previous slide. And here's the margin of it. As you can see, it's not encapsulated. It is circumscribed. And the dilemma is to know what this might do. And the point is that we really cannot tell unless you have the opportunity to follow such a lesion, to have biopsy it without taking it all out, and to follow it and see what it does. Also, we are faced with the problem of trying to say whether something is benign or whether it's malignant. And I don't believe the biologic behavior of mammary neoplasms in this species really takes this into account. I very often will question, although something may look benign at this moment, I very often question as to whether it really will have a benign course. Obviously, if you excise this lesion completely, then perhaps you could say that it was benign because it didn't recur. But if you left it in place, and it looked just like this, how soon or would it eventually look like an adenocarcinoma? And I think this is where we stand at the moment. I think some of the studies that are being done here and elsewhere will eventually lead us to more information and a more careful, a more soundly based understanding of what these neoplasms do in this species.